Good afternoon or good morning, and welcome to today's virtual briefing on overcoming barriers to adult hepatitis B vaccination. My name is Rhea Racho. I'm the Public Policy and Program Manager for the Hepatitis B Foundation, and I will be your moderator for the webinar. Before we get started, I just want to take a moment to review a few logistics for participating in the webinar. In order to view the presentation slides and to see our panelists on video, please use the link that was provided to you upon registration to join from a computer. For sound, you can either select computer audio or phone call. The number to join by phone is listed on the slide that you're seeing right now, along with the access code that you'll need, or you can find these under the audio tab in the GoToWebinar control panel on your right side. Or again, you can find the same information in your registration email. Please note that all attendees are in listen-only mode and you'll be muted for the entire webinar. At any time throughout the webinar, if you would like to type questions or comments, please do so in the question box, which is shown on the right side of your screen, also part of your GoToWebinar control panel. We'll be monitoring the question box throughout the webinar, and after the conclusion of all of our panelist presentations, we will answer as many of the questions as we can. Now, I just want to take a moment to introduce our organization and our partners in coordinating today's briefing. So the Hepatitis B Foundation is the only national nonprofit dedicated to finding a cure for hepatitis B and improving the quality of life for those affected by the disease worldwide. Our work includes outreach and education, public health research, and national advocacy. And through our Baruch S. Blumberg Research Institute, the Hepatitis B Foundation is also leading the way in biomedical research towards hepatitis B drug discovery and early detection methods for cirrhosis and liver cancer. Along with our partner, the Association of Asian Pacific Community Health Organizations, or APCHO, the Hepatitis B Foundation co-founded and now co-chairs the National Hep B United Coalition. Hep B United is dedicated to reducing the health disparities associated with Hep B by increasing awareness, screening, vaccination, and linkage to care for high-risk communities across the U.S. For anyone who's not aware, hepatitis B disproportionately impacts Asian, Pacific Islander, and African communities. Currently, Hep B United is comprised of more than 40 partners in 20 states and D.C., and collectively, our coalition screens over 20,000 people every year for hepatitis B, and we participate in local and national advocacy. Hep B United also partners with CDC on a co-branded multilingual awareness campaign called No Hepatitis B. And I also want to take a moment to thank our partners from the hepatitis advocacy and immunization advocacy communities who coordinated with us and supported us in hosting today's briefing. So thank you to APCHO, the Adult Vaccine Access Coalition, National Viral Hepatitis Roundtable, the AIDS Institute, NASDAD, and Hepatitis Education Project. All right, and before I turn it over to our first panelist, I did want to also provide some brief background on today's topic. Today, April 30th, we recognize as National Adult Hepatitis B Vaccination Awareness Day. The timing is perfect because this last week of April is also World Immunization Week, and tomorrow, May 1st, is the start of Hepatitis Awareness Month. So some people may be wondering why an awareness day was needed specifically for hepatitis B adult vaccination. But as you'll hear from our panelists today, there are many reasons, but I think it can simply be boiled down to the fact that we have had a safe and effective vaccine for hepatitis B for over 30 years. But while significant progress has been made in vaccinating infants and children, and so our younger population has a higher vaccination rate, the adult population, those 19 and older in the U.S., among that population, overall only 25% are vaccinated against hepatitis B. Oh, let me go back to that back slide. So as I mentioned, the Hep B vaccine was first introduced in 1985. It's widely used and among one of the safest and most effective vaccines. It requires 3 doses over 6 months. But more recently, a new vaccine was approved in 2017 that requires only 2 doses over 1 month and is highly effective in populations that may be harder to vaccinate. And this is particularly important because, again, as you'll hear a little bit more from our panelists, we have seen increases in reported cases of acute hepatitis B, primarily in states heavily impacted by the opioid crisis, as hepatitis B is spread through direct blood-to-blood contact, and injection drug use is a risk factor for acquiring hepatitis B. 1 in 4 individuals with unmanaged chronic Hep B will develop cirrhosis, liver failure, or liver cancer, which is the second deadliest cancer in the US, and only has a 5-year survival rate of 18%. Hepatitis B is also the #1 cause of liver cancer globally. So with all of that in mind, last year, with the help of our congressional champions in the House and Senate, there were 2 resolutions introduced to designate April 30th as National Adult Hepatitis B Vaccination Awareness Day. The House resolution was introduced by co-chairs of the Congressional Hepatitis Caucus, Congressman Hank Johnson from Georgia and Representative Grace Meng from New York, 2 of our strongest congressional champions for hepatitis. And in the Senate, a similar resolution was introduced by Mazie Hirono of Hawaii, along with the original co-sponsor Angus King of Maine. And the point of the resolutions was to recognize the importance of needing to increase hepatitis B testing, vaccination, and linkage to care, trying to encourage a deeper commitment to increasing adult Hep B vaccination rates while maintaining childhood Hep B vaccination rates, and promoting a greater awareness among healthcare providers and the general public. Lastly, I just wanted to know, I know this is a challenging time right now to talk about issues other than COVID-19. So first of all, I do want to thank all of you, our panelists and attendees, for taking the time to talk about this very important issue. We are monitoring the impact of how COVID-19 is affecting people living with chronic conditions like viral hepatitis. And we know that there are many of you who are completely swamped working on the front lines and have all of your priorities focused on this right now. But as we are looking forward to opportunities to increase our public health infrastructure and learn lessons from what's happening right now in the COVID-19 response, we think there are a few things that we can also talk more about in the discussion, but I just wanted to share some considerations that the Adult Vaccine Access Coalition and many of the partners have been advocating around in terms of how we're looking at our immunization infrastructure right now and what weaknesses or gaps are being highlighted in the COVID-19 response, since that ties into some of the strategies that we'll be talking about for hepatitis B vaccination. In general, looking at strengthening and enhancing immunization infrastructure is, as we're preparing for a COVID-19 vaccine, it's important to simultaneously ensure that our health system can continue to effectively manage ongoing routine vaccination efforts, such as hepatitis B or the annual flu vaccine. Funding will be needed from Congress to help for CDC to ensure that state and local health departments, agencies can prepare for and carry out mass vaccination. That would include resources for stronger immunization information systems, resources for additional staffing, as well to onboard providers and assure orderly vaccine distribution. And with all this going on, it's also still very important for continued messaging around the importance of routine preventive health and standards of immunization care to address the existing gaps in vaccine confidence and trust in vaccines. All right, so now I am going to hand it over to our first panelist. Dr. Noelle Nelson joined the CDC's Division of Viral Hepatitis 7 years ago and is currently the Prevention Branch Chief and Acting Division Director. At CDC, she has overseen national efforts to test, implement, and monitor hepatitis B, care and cure cascades, perinatal hepatitis B and C prevention projects, and viral hepatitis guideline development. Dr. Nelson focuses on Hep A and B vaccine recommendations development and was the lead of the Viral Hepatitis Vaccines Working Group of the CDC Advisory Committee on Immunization Practices from 2014 to 2019. So Dr. Nelson, I will hand it over to you to get us started.
Thank you very much for inviting me to today's webinar. Also, I'm here on behalf of Carolyn Wester, who is on the COVID-19 CDC response right now. Next slide. I will give a brief overview of hepatitis B vaccine policy, vaccine coverage, and hepatitis B epidemiology, and then speak about CDC's approach to hepatitis B prevention. Next slide, please. And I'll start with hepatitis B burden and vaccine coverage. Overall, hepatitis B vaccine policy has positively impacted the number of acute hepatitis B cases in the United States. Hepatitis B vaccine was first recommended for high-risk groups in 1982, then for infants born to hepatitis B viral-infected women in 1984, for all U.S. infants in 1991, and all children in 1999. The birth dose was recommended at the end of 2005. Hepatitis B vaccine was recommended for adults with diabetes aged less than 60 years in 2011, and was shared clinical decision-making recommendations for adults with diabetes aged 60 years or above. Next slide, please. Implementation of routine hepatitis B vaccination has lowered rates of acute hepatitis B for younger age groups, but rates are rising for persons aged 40 through 59 years old who are likely unvaccinated. The highest reported acute hepatitis B rate in 2017 was among persons aged 40 to 49 years. The rate was 2.55 reported cases per 100,000 population for those in this age group. The next highest rate was for persons aged 30 to 39 years at 2.33 cases per 100,000 population, and then 50 to 59 years at 1.62 cases per 100,000 population. And not shown on this slide, the number of estimated chronic hepatitis B viral infections in the United States is about 862,000. Next slide, please. While national incidence of acute hepatitis B has been relatively stable, in 2017, certain states experienced increases. State-level trends were influenced by the opioid crisis and lack of protection among populations for whom vaccination is recommended. Reporting also varies by state due to lack of national surveillance infrastructure and low levels of funding resources for hepatitis B. In turn, jurisdictions often rely on the epidemiology in their jurisdictions to make decisions to support hepatitis B prevention efforts, which impacts national programs. The states with the highest reported rates per 100,000 population are shown on this slide. The national average rate per 100,000 population in 2017 was 1.1. However, West Virginia had a rate of 11.7, Maine 5.8, Kentucky 5.3, and Tennessee 3.2 cases per 100,000 population. Next slide, please. New Advisory Committee on Immunization Practices hepatitis B vaccine recommendations were published in 2018. A new hepatitis B vaccine statement, and as was mentioned in the introduction, a policy note recommending HEPLISAV-B for active immunization against HBV infection among persons aged 18 years and older in a 2-dose series over 1 month. Hepatitis B vaccine is recommended for all infants, unvaccinated children aged less than 19 years, persons at risk for infection by sexual exposure, persons at risk for infection by percutaneous or mucosal exposure to blood, and others, including international travelers, persons with hepatitis C, persons with chronic liver disease, persons with HIV, and incarcerated persons. More detailed recommendations are available on a slide at the end of the presentation for your reference. Next slide, please. This graph shows the hepatitis B birth dose coverage from 2003 through 2018. As you can see, the vaccination coverage has increased substantially since the universal birth dose recommendation at the end of 2005, but has been stable at around 70 to 75% since 2011. The 0 to 3 day coverage rate is the highest it's been since the birth dose was recommended, though the Healthy People 2020 target is 85%, and current coverage is still well below that goal. However, estimated hepatitis B vaccination coverage for children aged 19 through 35 months of age has met the Healthy People 2020 goal of 90% for almost 2 decades. Next slide, please. This slide shows the hepatitis B vaccine coverage for a complete 3-dose series among adults aged 19 years and older from the 2017 National Health Interview Survey. Overall, the hepatitis B vaccine coverage was 25%. Coverage was 32.8% for travelers, 36.7% for persons with chronic liver conditions, and 60.5% for healthcare personnel overall. That's about 70% for healthcare personnel with direct patient care and about 42% for healthcare personnel without direct patient care. This is well below the Healthy People 2020 target of 90% for healthcare personnel overall. Hepatitis B vaccine coverage was 25% for persons with diabetes aged 19 to 59 years, and 12.6% for persons with diabetes aged 60 years and older. As you can see, hepatitis B vaccine of at-risk adults needs improvement and remains low. Next slide, please. Now I will talk about a few CDC hepatitis B focused initiatives. The ACIP Hepatitis Vaccines Work Group comprises professionals from academic medicine, federal and state public health agencies, and medical societies. The work group typically meets monthly and is currently focused on evaluating the evidence base for a universal approach to vaccination of adults against hepatitis B. Potential considerations for universal adult hepatitis B vaccination include closing the gap in adult vaccination coverage, providing protection to individuals who might be reluctant to disclose certain risk factors to their healthcare provider, providing simplified recommendations for providers, making it feasible for providers to stock hepatitis B vaccines, and creating opportunities for vaccination prior to onset of behaviors or practices that put persons at increased risk of infection. Next slide, please. To inform ACIP deliberations, the Division of Viral Hepatitis is engaged in economic modeling studies. One is to assess the cost-utility analysis of achieving universal vaccination of all adults aged 19 years or older compared to current vaccination recommendations and coverage levels. The second is assessing the cost-utility of providing the 2-dose HEPLISAV-B vaccine compared to a 3-dose Engerix B vaccine among adult populations currently recommended for vaccination. And this study is focused on the following populations: adults with diabetes, obesity, chronic kidney disease, HIV, and non-responders to hepatitis B virus vaccination, as well as elderly persons and persons who inject drugs. Next slide, please. Through a national funding opportunity in the Division of Viral Hepatitis, recipients implement and maintain viral hepatitis prevention efforts by identifying ways to integrate prevention, vaccination, testing, and linkage to care into existing public health, clinical care, and community settings. As a supplement to the national funding opportunity, 9 jurisdictions focus on high-impact settings, including syringe service programs, substance abuse treatment, correctional facilities, and hospital emergency departments. The goal is to increase hepatitis B and C testing and detection of current infection, increase the number of people who are aware of their current infection status, and an increased linkage to appropriate medical care for clients with current hepatitis B viral and/or hepatitis C viral infection. And partnerships are encouraged and part of this funding opportunity, in particular to ensure that persons who inject drugs have access to preventive services, such as hepatitis B vaccination. Next slide, please. One of CDC's collaborative projects was created in consultation with the HHS Office of Infectious Disease and HIV/AIDS Policy and the CDC Division of Oral Hepatitis. The goals of this project are to implement strategic partnerships between community-based organizations serving at-risk communities, departments of health, perinatal hepatitis B programs, safety net providers, research centers, and healthcare facilities. The project aims to identify best practices for implementation of comprehensive, culturally competent, community-based hepatitis B education, screening, vaccination, and treatment programs in disadvantaged and minority communities. Next slide, please. And then the United States Perinatal Hepatitis B Prevention Program, funded and run by the National Center for Immunization and Respiratory Diseases at CDC, in collaboration with the Division of Oral Hepatitis, where we provide subject matter expertise to the program. This program funds 64 jurisdictions, and the goals are to ensure identification of all hepatitis B infected pregnant women, timely receipt of infant prophylaxis, including vaccine and immune globulin at birth, timely post-vaccination testing after completion of the hepatitis B vaccine series to identify new cases early and to ensure response to vaccination, and revaccination of infants who do not respond to the hepatitis B vaccine series. Next slide. And the next slide. So CDC is in the process of developing a viral hepatitis 2020 to 2025 strategic plan. The goals and objectives for hepatitis A, B, and C with specific outcome measures, including measures for monitoring outcomes among disproportionately affected communities. This plan is aligned with the HHS National Viral Hepatitis Strategic Plan and the Healthy People 2030 goals. Thank you.
Thank you, Dr. Nelson. Our next panelist is Fatima Thierry-Reed. She's the director of the hepatitis team at NASTAD, where she leads programmatic and technical assistance initiatives related to viral hepatitis. Prior to NASTAD, Fatima served as chief of the Center for Viral Hepatitis at the Maryland Department of Health, coordinating departmental and statewide efforts to prevent, control, and treat viral hepatitis. Thank you for joining us, Fatima.
Thank you for having me, Rhea, and thank you to all of you, I missed what the current count is, but who have joined us for the webinar today. As Rhea mentioned, my name is Fatima Thierry-Reed, and I am the Director of Hepatitis at NASTAD. NASTAD is a Washington, DC-based nonprofit where we focus on providing technical assistance and capacity building to health department viral hepatitis, HIV, and harm reduction programs. I'm excited to talk to you today as we observe National Adult Hepatitis B Vaccination Awareness Day about a project that took place back in 2012, but really provides us with an opportunity to look at some of the lessons learned from our efforts to expand adult hepatitis B vaccination in the past and how we might learn from that work and expand upon that work moving forward. So I'll briefly discuss CDC's hepatitis B vaccination pilot today, talk about the work that we did in Maryland through this pilot, and then share some very brief takeaways. Next slide, please. So the hepatitis B vaccination pilot was a 3-year CDC-funded program with the goal and a focus on reducing hepatitis B through the provision of expanded hepatitis B vaccination, specifically amongst adults. Next slide. Thanks. The pilot was part of a $35.5 million CDC-funded initiative that had a focus on really building and expanding upon our immunization programs within the country so that we could have a stronger infrastructure to provide immunization, both childhood and adult immunization. All 64 CDC-funded state health department immunization programs were eligible to apply, and there were 9 program areas. Program area number 7 specifically focused on hepatitis B vaccination and was the focus area that funded the hepatitis B vaccination pilot. Next slide, please. So just to give you a brief overview of the program, there was about $4 million that was awarded to 14 grantees. And I do want to take a moment to acknowledge each of the grantees. There were 11 states: Alabama, Florida, Kentucky, Louisiana, Maryland, Michigan, Nevada, Oregon, Tennessee, Virginia, and West Virginia, and also 3 cities, so San Antonio, Chicago, and New York City. Across these 14 jurisdictions, they administered vaccine in 459 different settings. At the start of the project, there was 161,171 doses of vaccine that were ordered to be administered. In terms of data collection, there were multiple methods there were multiple tools, I apologize, that were used for data collection, including each of the state's own immunization information systems. Next slide, please. All right, and then just to give you a quick glimpse, for the hepatitis B vaccination pilot, so this is across all 14 participating jurisdictions, we prioritize settings where there was a high proportion of individuals who had risk factors for hepatitis B infection. So specifically, correctional facilities, healthcare facilities serving people who use drugs, as well as healthcare facilities serving gay, bisexual, and other men who have sex with men. And then also you see that setting category of other, and I'll come back to that in just a moment when I talk about the Maryland model. Next slide, please. So let's jump right into it. In Maryland, at the time that we initiated or actually applied for the hepatitis B vaccination pilot, there were about 5.8 million people living in the state. About half of them were white non-Hispanic, another 30% Black and African American, 8.7% Hispanic or Latinx, and 6% Asian. About 13.8% of Marylanders at that time were born outside of the US. 15 to 17% of adults were uninsured, and there were 1.2 acute hepatitis B cases per 100,000 total population. And again, this was looking at 2010 as we were preparing to apply for the pilot. Next slide, please. So of course you want to know, what did Maryland's program actually look like? Well, we received just under $400,000 for our hepatitis B vaccination pilot. The Maryland Department of Health was the main grantee, and there were 15 sub-grantees, 10 local health departments, and 5 community-based organizations. We received 14,500 doses of hepatitis B vaccine to support adult Hep B vaccination, and worked across 43 settings in 6 different counties. Our main software that we used for data collection was Immunet, as well as localized instruments at each of the participating sites. Next, please. Just to give you a quick taste of the program services that were provided, the Maryland Department of Health provided to our partners the vaccine that I just noted, training, storage and handling procedures, as well as other protocols. We supported infrastructure development at the sites, and of course we oversaw monitoring and data collection on all of the project activities. our partners were the ones who were critically involved in administering vaccine to individuals who needed it most in those priority settings that I mentioned earlier. And they, in the course of the project, supported outreach and hepatitis B education, screening, vaccination, linkage to care, and treatment. Though I will note that not all of these services were specifically funded by the project itself. Next slide. So something I wanted to highlight here is that all of the settings that were prioritized over the 14 jurisdictions were prioritized in Maryland. But something that I think made us a little bit unique, and something that happened within all of the jurisdictions as they looked to prioritize some of those most critical populations for them to outreach to, was the fact that our 5 CBOs partnered with clinics that specifically served Asian, Pacific Islander, and African patients and clients. And this was not a situation where due to the project, we were for the first time outreaching to these communities. These were community-based organizations who we had partnerships with and who were actually embedded within these communities. Why that was important is that it really helped us to ensure that we were providing culturally significant and linguistically appropriate services to each of the participants who received outreach, education, vaccine services, as well as linkage to care. Next slide. So in the brief time that I have with you today, I just wanted to highlight some of the key things that we learned from the project and some of the key outcomes. So for Maryland's hepatitis B vaccination pilot, a critical outcome that I want to highlight is that there were 10,014 doses of vaccine that were administered. So that's out of the 14,500 that I noted earlier on. Of those 10,000 doses, 35% were second dose, 22% were third dose, and the remaining were all first dose. If you're looking and kind of doing the math and saying 10,000 out of 14,500 leaves a lot on the table, fortunately, we were able to continue providing hepatitis B vaccination to at-risk adults after the project's close in 2015 and administered an additional 3,486 doses. Next slide, please. And I'll make one additional note. We did have some waste, which was something that grantees experienced across the project. Unfortunately, there were about 1,000 doses that were lost due to storage and handling procedures, as well as individuals who had agreed to receive vaccine and then changed their mind after the vaccine had been prepared to be administered, as well as a few that expired very early on in the project. All right. So to specifically talk about the hepatitis B vaccination pilot in terms of outcomes across the board, I did want to highlight some key findings. I'll go through these quickly, but just want to note that there was a manuscript that was developed. At the end of my slides, I do reference it and provide a link if you'd like to read a little bit more about the overall project. But in terms of the demographic characteristics of the patients who were served over the course of the project across the 14 sites, most were between the ages of 25 to 44 years old. So getting at that critical age group that Dr. Nelson mentioned earlier, were living with chronic hepatitis B. Additionally, they were primarily male and also non-Hispanic white, though there was a lot of variation across the sites in terms of these demographic characteristics. Next slide. Of course, also critical to note are how do we do in terms of, how did we do in terms of series completion when it came to hepatitis B vaccination under the pilot? So I'll go back to that preliminary number that I presented, 161,171 doses of vaccine ordered and distributed. Of those, 91% were actually administered. And then in terms of data collection, we were able to account for 138,665 of those doses administered. And of those, 52.7% were the first dose in the 3-dose series. 23.3% were the second dose in the 3-dose series, and 18% were the third dose. Next slide, please. All right, so with just a couple minutes remaining, I wanted to jump into some of the key takeaways. So of course, there are a number of lessons learned, a number of challenges, and a number of successes that I could highlight. But I decided to really focus on the key takeaways due to the short time that I have with you today. So one of those is the fact that series completion is challenging, but we absolutely can achieve series completion. Why do I say that? One reason is because of health data modernization. Back in 2010 through 2012, when we started this project, only about 54% of outpatient clinics had adopted electronic health record systems. By the time we were closing the project, we were closer to 92%. That means that we were in a better place to be able to track patient information, utilize patient contact information, especially when working with outside partners like we did in this project. And therefore, we could do things like send automatic reminders to patients so that they could come back in to complete the series. Also, prompts for providers to remind them to administer doses to their patients when they're coming in for other services. Another piece is that the 2-dose series is now available. So now you can be vaccinated for hepatitis B with just 2 doses, which shortens, which removes the need for that third dose that we weren't as successful at getting. And also we learned from the project the importance of really meeting people where they're at in order to be able to get them to complete the series. And I think that's an important theme for us to carry forward. Additionally, dedicated funding for adult hepatitis B vaccination is absolutely critical. At this time, we don't specifically have a designated pot of funding to support adult hepatitis B vaccination. And working closely with health departments all across the country, it's something that we hear time and time again as a significant barrier to them being able to really implement adult hepatitis vaccination for A and B in a way that we need to. And then finally, collaboration across healthcare, public health, and community is absolutely essential. One of the reasons we've been able to really improve rates of vaccination for children is that there's coordination across healthcare, public health, school systems, auxiliary organizations, and that's why we've seen those increases in childhood vaccination. We need to do the same for adults and ensure that we are providing adult vaccination where adults receive their services embedded within their communities. And with that, thank you for your time.
Thank you so much for providing an overview of the pilot program and also a look more deeply into Maryland's experience. That was really helpful. I would like to introduce now our third panelist, Jason Stern. Jason is Chief Operating Officer at Hepatitis Education Project, a Seattle-based nonprofit organization committed to improving the health of underserved communities disproportionately impacted by viral hepatitis. In this role, Jason oversees grant management and strategic plan development and the organization's health policy and advocacy efforts at the local, state, and federal level. Thank you, Jason. I'll turn it over to you.
Good afternoon. Thank you, Rhea, and thank you to the co-sponsors for inviting me to talk today on Adult Hepatitis B Awareness Day. I hope you're all doing well during these difficult times as the COVID-19 pandemic continues to hold a grip on us all. I want to thank those on the call who are working tirelessly within our government for their leadership and commitment to making decisions that are grounded in evidence and support the safety of us all until the science, not the politics, says otherwise. I also want to take a moment to thank the frontline workers for their selfless dedication. I'm fortunate to live in a state where harm reduction programs like our agency in Seattle was deemed an essential service. This means that many marginalized and extremely vulnerable communities we support have access to life-saving evidence-based services we provide. So I want to thank the team at HEP and the harm reduction programs across the US for their commitment and dedication. I'm going to talk today about an initiative within our agency to increase adult hepatitis B vaccination in vulnerable communities through a comprehensive harm reduction approach. Next slide. The Hepatitis Education Project, or HEP, is a Seattle-based nonprofit organization that is providing support, education, advocacy, and direct services for people affected by viral hepatitis for over 25 years. HEP is a leading agency in supporting policy change to improve access to care and treatment and increasing city, state, federal, and viral hepatitis funding. Next slide. HEP started in 1993 primarily as a series of support groups for people newly diagnosed with hepatitis C, whose experience was largely characterized by lack of information about the virus itself, and few, if any, treatment options. With the introduction of direct-acting antivirals in 2015, HEP's historical demographic of baby boomers were more rapidly linked to treatment and cure. Over time, the overdose crisis has led to a drastic shift in those infected with viral hepatitis, pivoting HEP's demographic focus towards a younger, more vulnerable group of individuals, primarily people who use and inject drugs. Communities disproportionately impacted by viral hepatitis are often marginalized, underserved, and disenfranchised from the healthcare system, who can face numerous barriers to accessing care that impedes prevention, testing, linkage to care, and treatment. Some of these determinants of health inequity include stigma and discrimination, language and cultural insensitivity, education, incarceration, mental health, and socioeconomic status. Next slide. To provide comprehensive holistic care and improve health outcomes to address the new challenges our populations face, HEP has developed a person-centered care model. Every person has unique needs, experiences, and perceptions. Thus, a one-size-fits-all solution isn't effective. HEP's first hepatitis B program started in 2011 as a CDC-funded screening and vaccination program within API and African-born communities. Since 2011, HEP has worked with our public health department to continue offering free vaccination in communities disproportionately impacted across the state. HEP and other programs includes prevention and outreach that provides health education, syringe access, naloxone distribution, infectious disease testing, vaccination, and low-threshold wound care to over 100 partner sites across Washington state, including opioid treatment programs, drop-in centers, shelters, health fairs, and homeless encampments. HEP's medical case management program is one of the first of the kind in the country, responsible for identifying people living with viral hepatitis and linking them to medical care, treatment, and cure. Our case managers act as a vital source of emotional and educational support for patients and their families. In 2019, HEP partnered with a local FQHC and a behavioral health organization to establish an innovative and low-barrier medications for opioid use disorder treatment clinic. This collaboration is located at HEP during a syringe exchange. HEP's correctional health program was created in response to the disproportionate disease burden of viral hepatitis in the correctional setting. Since 2003, HEP has contracted with Washington State Department of Corrections to deliver hepatitis education courses at all prisons and work camps in Washington State. HEP is a global leader in the policy space, working with the World Health Organization, CDC, and state and local policymakers to amplify the need for increased access to viral hepatitis testing and treatment. Next slide. Meeting people where they're at and the ideology of reducing harm is a guiding principle for our programs and services, which governs how we engage with individuals. We strive to create an ethos that's of acceptance and understanding and non-judgment. It is because of these foundational values, people in our community choose to receive services at HEP. The clients we serve are stigmatized and regularly discriminated against. They must navigate a complex and fragmented health and social service system to receive basic care for their health needs. This feeds into a vicious cycle of deteriorating health and accessing care only when it is an emergent need, generally through emergency departments. It is not surprising trauma has created fear and mistrust for the healthcare system. The rapport and trust developed with the clients we serve is why people come back day after day, week after week. Harm reduction programs can therefore be critical access points for comprehensive care. When someone comes to our syringe exchange, we have the opportunity to educate them on overdose prevention, offer them a hepatitis test or vaccine, or let them talk with a nurse about a wound before it gets to the point that they have to go to an ED. Our case managers can offer wraparound referrals to other social and health services as needed and help address their holistic health. And lastly, in the time of COVID-19, harm reduction programs may be the only services this population is utilizing. When a COVID vaccine is available, it'll be important to consider harm reduction programs as a potential access point to many disenfranchised communities. Next slide. So tying this all back to adult hepatitis B vaccination, we know that despite availability of a highly effective vaccine, hepatitis B new infection rates have begun to increase in recent years after many years of a downward trend. This worrying spike in new infections is largely attributed to the nation's ongoing overdose crisis. These next two slides are from the 2017 CDC report using data from the National Notifiable Disease Surveillance System. It was reported that of the acute hepatitis B cases in the US, about 30% identified a risk as a potential cause of infection. Next slide. Furthermore, this report indicates that injection drug use is the #1 reported risk factor for new hepatitis B infections. Next slide. When you compare the transmissibility of hepatitis B compared to other infectious diseases of concerns when sharing injection equipment, such as hepatitis C and HIV, hepatitis B presents a much higher risk of infection after blood exposure. Next slide. When I was putting this brief together, I thought I would Google hepatitis B and opioid crisis and find countless news articles reporting this. There were a few, but honestly, I was surprised to see it just wasn't getting covered in the media. We know hepatitis B new infections are on the rise, and we know new infections and new cases are driven by injection drug use, but we aren't talking about this linkage enough. And this is part of the problem, and why I'm here today underscoring the importance of testing and vaccinating for hepatitis B, and A, we can't forget about A, and people who use drugs and people experiencing homelessness. Next slide. At our SSP in Seattle, Washington, we started testing for hepatitis B more widely. The data from that program showed that of those tested for hepatitis B, 23% had been exposed and developed an infection from the virus, where 7% had a current hepatitis B infection and 16% of those tested had resolved an acute infection. Furthermore, a total of 68% of those tested at HEP had not been adequately or timely vaccinated against hepatitis B. These alarmingly high hepatitis B infections observed in this community is exacerbated by the transmissibility of hepatitis B virus when sharing injection equipment and the low vaccination rates. And this is consistent with what other studies of similar populations have reported. Next slide. I was asked to talk about a few challenges and barriers to implementing hepatitis B vaccination in community-based harm reduction programs. And this, by all means, is not a complete list. Harm reduction programs play an important role in testing and vaccinating for hepatitis B, but generally require highly competitive grant funding and in-kind support to implement, as we can't bill for services. We've already discussed the fear and mistrust of the healthcare system and competing health priorities in the lives of the communities impacted. Which leads to the final point. The communities we support are difficult to access, so follow-up can be difficult. We often can't reach folks easily by phone or email, and there's so much displacement of people experiencing homelessness that creates chaos in their everyday lives. So some strategies or tips to overcome these barriers. Where possible, include vaccination in existing efforts. Talk with funders and grant managers about the need to include these services. Meet people where they are. Our outreach team works in homeless encampments, under bridges, and alongside freeways to reach folks. Build rapport and trust. A familiar, friendly face goes a long way. Consider other health and social service needs so that vaccination is part of the broader care plan. And ask your health department for the 2-dose vaccine, which is highly effective and only requires one follow-up reminder 30 days after the initial dose. This compares to the 3-dose vaccine, which requires follow-up up to 6 months after the initial dose. Next slide. The rising rates of hepatitis B among persons who inject drugs requires a concerted public health effort and additional federal funding to increase testing and vaccination within programs that serve these vulnerable communities. To be effective in our work, we need to increase funding to the Division of Viral Hepatitis at CDC, broadly for increasing surveillance, prevention, and testing efforts. We need flexibility and directive for hepatitis B vaccine administration from federal agencies such as SAMHSA, HRSA, HUD, and IHS. We need to increase funding to CDC for infectious disease consequences of the opioid epidemic, to hyper-focus on issues like I've described today. And we need CDC and HHS to increase awareness of this issue and provide guidance on best practices, like the value of the latest 2-dose hepatitis B vaccine. And lastly, we need to remove the ban on syringes and other restrictions using federal funds. Next slide. That's it.
Okay, thank you, Jason. All right. So this is great. So we've heard from our partners, our federal partner at CDC. We've heard of the perspective of the state health departments and also a community-based organization. And now we're going to hear from Dr. Camilla Graham, who will provide more of a clinical expertise and talk to us more about her experience with challenges and barriers to adult Hep B vaccination. Dr. Graham is an infectious disease physician at Beth Israel Deaconess Medical Center, and she's medical director at Program RISE, which provides STI testing and treatment, needle exchange, and vaccinations. She's been involved with hepatitis B and C testing programs and work to simplify the management of viral infections. Thank you for joining us, Dr. Graham. I'll turn it over to you.
All right, thank you. So what I'm going to be talking about today is hepatitis B vaccine in adults in the hospital setting. And I titled this section, "We Can't Know the Future, but we can try to protect ourselves from it." Because as an infectious disease doctor, I'm thinking about how do I reduce infectious risks for both individuals and for communities. And vaccines are at the essence of these initiatives. One thing that we need to think about with vaccines is we don't usually wait until it's imminently clear that someone needs the vaccine before we actually administer it. We don't plan to get polio. We don't plan to get measles. We vaccinate most children early in their lives so that they have lifelong protection against the infection. And we are doing that with hepatitis B with children in the United States now. And you saw with the first presentation, the dramatic decrease in the number of infections in our young people. Unfortunately, as you also saw, we are doing a terrible job with adults. Next slide. All right, so one thing I want to start with is the idea that there are a whole lot of things that are easier if you've never been exposed to hepatitis B. I do want to emphasize that we have very good treatments for hepatitis B now, and if you have been identified, you can take advantage of those. But still, medical care is more complex if you've been exposed, and I'm going to give you some examples. So one is that if you've been exposed to hepatitis B, even though you managed to clear it, immune control it, that virus is hiding in your liver. And if something happened to your immune system, you developed cancer and required chemotherapy, you developed an autoimmune disease and needed immunosuppressive medicines to treat that, that hiding virus can come back out. It can reactivate, and in some people can cause very serious liver disease or even death. Another way that we found that hepatitis B was actually impacting the recent COVID-19 virus is when you think about some of the experimental drugs in clinical trials right now. One clinical trial requires that people's enzymes aren't above a certain threshold, aren't too high. And people sometimes with hepatitis B may have elevated liver enzymes. Another is looking at a couple of drugs that suppress that overexuberant immune response that some people get with severe COVID-19. And there's a theoretical risk that those drugs themselves could reactivate hepatitis B. So if you were vaccinated, you would have been protected and you wouldn't have been at risk for some of these additional medical complications. Next slide. So you saw this list of conditions, exposures, diseases, complications previously where we recommend that somebody get the hepatitis B vaccine series. And I want to point out a few problems with this. One, some of these categories are very difficult to program into the electronic medical record system. And that for us is the easiest way to remind ourselves and others about appropriate care for patients. And so if you can't code it, then it's hard. It's much more likely for people to slip through the cracks. The other is you're looking at someone today, but you don't know what future person might have happened to them. So I'll give you an example. Today, we are not traveling because we're all trapped in our homes. But at some point in the future, each of us may want to travel, and perhaps to a country where it's recommended that you get hepatitis B vaccine. And one thing we've realized is as people get older, they may not respond quite as well as somebody who's younger. And so getting it today to protect your future self who wants to travel, it might end up with better protection. Another example is diabetes. 40% of us, the CDC says, are anticipated to develop diabetes at some point in our lives. I'm going to show you data on the next slide. You may respond better if today you get vaccine as opposed to waiting for future you to develop diabetes and then get vaccinated. Next slide. So here's a couple of studies. They're actually looking at the 2-dose vaccine that you've been hearing about in previous presentations compared to one of the older vaccines that was that 3-dose vaccine. But what I want to show you is in healthy people, 95% of people getting the newer vaccine developed immune protection, good responses to that vaccine. I will tell you that the people younger than 30, it was 100% that responded. So as you get older, it's a little bit less effective. And then when you look at people with diabetes, they had overall a 90% response rate. This is very, very good compared to the older vaccine that was only 65% in people living with diabetes. But it's still a little bit less than what you might have gotten if you were healthy. So getting it today to protect future you, because we don't know what might happen to each of us in the future, is probably the best approach. Next slide. Another thing is you really need to put hepatitis B vaccine initiatives within a broader hepatitis B program. And the U.S. Preventive Services Task Force has recommended that people test 3 different tests in order to identify the comprehensive care that people need around either preventing or managing hepatitis B. I went to my hospital system to see how well we were executing on these 3 tests that are needed. And I found that fewer than half of people who were getting some sort of hepatitis B test were actually getting the correct 3 tests. Our laboratory services said that we were just ordering it wrong sometimes. And then I went to one of our commercial labs, Quest. I'm not picking on them in particular, I just happened to look at them. And they had 27 different testing options that included hepatitis B. That can be overwhelming for clinicians. And none of them had all 3 of those required tests in the same package. Next slide, please. So what we did at Beth Israel Deaconess, as just an example, is we created something we called the Hepatitis B Screening Panel. And if you select that, you automatically get all 3 of those tests that you're supposed to get. And I would recommend that all labs, whether hospital-based or commercial, create similar panels for hepatitis B screening. Next slide. And then here's an example of how we've structured the ordering for the vaccine. We actually have hepatitis B as our default vaccine for all adults. And then if you fit into a category that's not covered by hepatitis B, you're given instructions about the type of vaccine that you need and the type of dosing you need. I will note that hepatitis B just came out with preliminary data in people with severe kidney disease on dialysis. It actually looks very favorable, but we have not changed our recommendation on that yet. Next slide. So I think in this presentation, I'm asking us to really strongly consider an all-adult testing program for hepatitis B. So not just vaccination, a comprehensive testing program. This will identify everyone with chronic hepatitis B infection. There's about 65% of people with chronic hepatitis B have not yet been diagnosed. It's going to identify people with no evidence of prior infection, of prior exposure to hepatitis B, who would benefit from vaccines, whether for themselves today or their future selves. And it will also identify the people with prior exposure to hepatitis B who could be at risk for that reactivation so that they receive appropriate management in the future. Thank you.
Thank you so much. Right now, we have reached our Q&A section of the webinar. So if our other panelists would like to join back on video, you are welcome to. I'm going to start filtering through questions. I'm also actually going to invite Lauren Canary with the National Viral Hepatitis Roundtable to join me in asking some of these questions. I'll be changing that setting in just a second. But while I'm doing that, I wanted to start with Dr. Nelson. Actually, there were several questions, a lot of interest around the revisiting of universal hepatitis B vaccination. So one of the questions was, when do you estimate the CDC plans to complete, or the ACIP will be revisiting this? And could you provide an estimate for costs that may be associated with implementing this plan?
Hi, thank you for the question. This is going to be, this process will take, potentially a couple of years. Part of the ACIP review process is doing a rigorous systematic review of the literature to provide the evidence-based needed to bring to ACIP meeting in a public forum. It's particularly now during the COVID-19 pandemic, it's challenging for me to give you an estimate. But we hope to embark on this literature review, as soon as possible, so that we were able to bring the findings to the ACIP work group. In terms of cost, we're just at the stage of completing these analyses that we will be presenting to the work group. These deliberations are closed until they're actually presented in the public forum, and we're not quite at the stage yet of presenting these data, but they will be published in peer review as well. Thank you.
Okay, thank you. And there was one follow-up question to that. Is there anything that the community can do to help ensure that the review is expedited, or given the immediate public health impact we're seeing in high-risk communities, if there are any opportunities that the community can contribute and help with this process?
I think the best is for the community to continue to encourage adult vaccination, particularly in high-risk settings. I can assure you that it is a priority of the Division of Viral Hepatitis, and we have staff dedicated to this problem and to complete these reviews. But I think just continuing to encourage adult vaccination is probably the best thing that the community can do.
Thank you. And this question is for Fatima. How much funding do state health departments receive from the federal government to address hepatitis B, and how many staff are typically devoted to Hep B prevention?
This is a great question. So I cannot answer that exact question in terms of for hepatitis B specifically, because that's not how the funding is actually broken out when it is awarded to the states for hepatitis B prevention. We did complete, NASTAD completed a needs assessment of viral hepatitis health department programs in 2019, where hepatitis programs did share the funding that they receive both from the Fed as well as state, general, private, and other sources of funding. But I unfortunately am unable to provide a specific breakout in terms of the funding that's provided for hepatitis B.
Okay, thank you. Let's see. I think this one may be it could be for anyone, maybe Cami. Do you test adults for hepatitis B surface antigen prior to immunizing? This test is less than $10. The person's making a comment. If you give Hep B vaccination prior to testing, this gives a false sense of security.
You know, there was actually an NIH study done years ago where they were looking at nurses that had been vaccinated early on in the when the vaccine first came out. And they went back, I think, to see how long the vaccine was working, and they found some of these nurses had chronic hepatitis B and had been given that false assurance. I think that's a very, very significant problem. You know, I also work at Program Rise, and it has needle exchange and other issues, and we have trouble getting funding for that full panel that I talked about of hepatitis B testing, but that's a real problem because we're going to start people on PrEP. We want to make sure that they don't have, you know, chronic hepatitis B before putting them on a treatment that has hepatitis B. We want to find the people who actually need vaccination, and so, you know, I think that testing is a real important part of vaccine programs. If you can't get the testing, you just vaccinate and you do the best you can, and you try to educate people that this may not necessarily mean that they're protected.
This is Noelle. I'd like to say that I completely agree with everything that's been said. And also, the Division of Viral Hepatitis is also working on updating our testing recommendations. It's been a number of years since those have been updated, and that's also an active process that's going on right now. Thank you.
Thank you.
Great. Thank you.
I had a question. I guess this would probably be most appropriate for Fatima and Noelle. I think we've got a great example to look at, a model, I suppose, for the human papillomavirus, where we saw a vaccine that is a cancer prevention vaccine like hepatitis B that cuts across many different health conditions. And I know we have a lot of staffers on the line thinking about budgets for CDC that trickles down to health departments. And these budgets tend to be, these line items are really focused on disease areas, which kind of silos our response. And given in the human papillomavirus example, we've been able to see STD programs work with immunization programs, work with cancer prevention programs to really get the word out and encourage uptake. So from what you've seen in our viral hepatitis programs, how can we ensure that we're working across these divisions? We're really breaking through those silos for a concerted effort to really improve vaccination.
I can touch on that, and then Noelle, definitely want to give you an opportunity to respond to that as well. I would just say, Lauren, you raise a really important point. I think HPV is one that we've been looking at, but I know from the early stages of my engagement in hepatitis work, Hepatitis B Foundation in particular has been encouraging people to recognize that Hep B vaccination was one of the first cancer preventing vaccines that we had available to us. And in terms of being able to work across, I think efforts that are taken by the federal government to engage us across funding sources is really helpful, and to ensure, you know, sometimes when we think we have to work from a specific stream of funding and therefore it can't be utilized to address other disease areas, though we know that they're directly related to one another or interrelated. I think sometimes when that guidance comes from our federal partners, it supports more integration across programs like cancer prevention, viral hepatitis, and vaccine programs.
This is Noelle. I think that this is a great question, and you know, one of the things that we're trying to do is to note the settings and funding opportunities to encourage you know, partnership building, and to encourage you know, prevention and treatment across different settings. For example, corrections, STI clinics, you know, and settings where persons who use drugs. And I think, you know, we also, of course, had hepatitis A outbreaks, and of course, we're also focused on hepatitis C. And I think, you know, we're trying across the board to really make sure that all of these settings are addressed in our prevention and response efforts. Thank you.
And if I could just add one additional piece to that, I think something that we have to consider too is that for viral hepatitis programs, oftentimes they have less than 1 FTE or 2 FTE. And so you have a small number of staff who are doing an incredible amount of work. So the more opportunities there are to work with other programs, especially that have more dedicated staff to support our viral hepatitis vaccination efforts, cancer prevention efforts, it means that we can be even more powerful in our work.
Great. Jason, you may be able to answer this one. We had a partner who was looking for a simplified one-page vaccine summary for people who use drugs and or are houseless. Are there any such resources for clients available?
That's a great question. I can't think of a one-pager in terms of just for vaccination for those communities. I'm sure that there is something available either on NVHR or HRC's harm reduction website, but I can get back to you on that, Rhea, and send that out through the list of specific to vaccines. I think it would be more comprehensive than just viral hepatitis, I would assume.
Great. Okay. Yeah, and if anybody else on the webinar today has ideas, you can send them to us. We'll put our email address up at the end to contact Hep United and Hep B Foundation. There's also some good questions here for Cami about, do you have any suggestions for getting buy-in for implementing vaccination programs in emergency departments? And there's a follow-up. Or actually another person asked a similar question. Can HBV testing or vaccination be offered as an opt-out in EDs like HIV testing, or is that already being done?
So somebody else might want to answer the opt-out. You know, the issue sometimes with emergency rooms is taking responsibility for that that next required action. So if you see somebody in the emergency room, you need to somehow either get them back a month later for the second vaccine, or you need, you know, some very clear way to link them into care for that second vaccine. You know, and so that's going to be very particular to each emergency room. And so I think that making a blanket policy might be a little bit complicated, but the other speakers might have some other comments about that. But, you know, I want to say, though, that this 2 vaccine series has really changed a lot of people's perception of the possibility of vaccinating people. And I think we haven't fully explored how we can really leverage this much more simplified regimen, because I think a lot of the thinking has been trapped back with that old, you know, three injections over 6 months. Our Department of Public Health, when we had an outbreak south of Boston among our people who inject drugs and homeless patients with hepatitis B, they went out and located people who might be at risk, vaccinated them, and had a remarkable follow-up for that second vaccine that I think really showed us, even in very difficult to reach patient populations, you can succeed with this vaccine in a way that you might not have even attempted with the older vaccine. So I do think there's an opportunity to rethink how we deliver vaccination.
Great. So I'm looking at the time. It is 4:15, but we have a lot of questions that are coming in. I'm wondering if the panelists maybe have like 5 more minutes to answer.
Oh, this is fun. Yeah.
I've got another one here. This is for Jason. We know currently SAMHSA doesn't appear to be funding hepatitis B vaccination in their sort of substance use treatment programs. And I understand you sort of on site are offering this sort of list of services for people that use drugs, so buprenorphine with hepatitis B vaccination, with hepatitis C testing. Would you mind speaking to anything that would make that work easier? I mean, like, how do you bring these things together? Was that difficult? Is there anything that could be done at the federal level, at SAMHSA and CDC, to kind of make more of that syndemic approach easier for your work on the ground?
Yeah, it's a great question, and I think that's a lot of what sort of needs to happen at the federal level, is that we need to start breaking down some of these silos and realizing that there is just so much intersectionality in all the work that we're doing, and that when we have an opportunity to engage in someone's health, we should take that opportunity to look at holistic health where it makes sense, and look at sort of all the co-occurring issues that are related. And we've had conversations with SAMHSA and sort of grant managers, and their response really is, well, that's just how the language is written, and that's how sort of the funding is being sort of moved out the door. So I think that there needs to be sort of direction from above that allows for more flexibility in how the grants are written and the language that's included in there, so that we can look at the communities that we're supporting and add various layers to that program where it makes sense, like hepatitis B vaccination. And we're piecemealing it together, and we're finding various funding sources and various projects to ensure that we're building those comprehensive services. And we're lucky to have a larger portfolio of programs that we can do that. But when we're sort of looking at programs across the U.S., it becomes very challenging, unfortunately. So yeah, it's a great question. I think having conversations with sort of the higher levels and breaking down the silos across agencies is so critically important.
Okay, and a question for Dr. Nelson. Is there an opportunity for the perinatal hepatitis B prevention program to follow women postpartum to ensure linkage to Hep B treatment and vaccination for household or family members?
That is an excellent question, and it's something that we've been talking about in the Division of Viral Hepatitis as a potential future focus, either of course in collaboration with the perinatal hepatitis B prevention program, but also potentially within the division. We don't have specific funding opportunity right now to address that, but it's certainly something we recognize as very important and critical to hepatitis B prevention.
Thank you. And maybe one last, I don't know if anybody has experience with this, but are there any best practices or initiatives you know of to encourage pharmacists to provide hepatitis B vaccination, and some strategies to make the vaccine more accessible?
I'll just pipe in. I think that's a fantastic initiative. People all go to Walgreens or CVS or whatever is in your area to pick up their toothpaste and the deodorant and whatever meds they might be on. They're there. The pharmacists are trained to give vaccines. That's where I got my shingles vaccine, because it was easier than trying to get it in my doctor's office. I really think we need to leverage all available health resources, and I think pharmacies have been underutilized in terms of the public health benefit they could provide.
Yeah, I'll just say really quickly, and don't want to put any of the viral hepatitis prevention coordinators on the spot, but a number of them have done outreach to pharmacists and to pharmacies to get them engaged in hepatitis testing as well as vaccination. So if you're not sure about what's happening in your jurisdiction, I would strongly encourage you to reach out and see if those efforts are already underway. Also, a lot of those efforts are happening with HIV programs, and they might expand them to hepatitis as well.
I'll just sort of add one additional point that sort of pivots a little bit from here. And I think this goes back to reimbursement. and what is a reimbursable service. And I think that looking at strategies that are transformational in our healthcare system, so that sort of non-traditional settings can be reimbursed for services like vaccination. CBOs is a really great example. We can't get reimbursed for the vaccinations we do, so we provide everything for free and at cost, and still we have to find grants to support that. So I just think looking at that sort of reimbursement model, and so that people can access the care they need wherever they are, like pharmacies or CBOs.
Yeah, I want to really reiterate what the other speakers said. We have to bring care to the people. We have to meet them where they are. And once we interact with them, we have to provide them. They don't know that we silo our funding. They don't know that we have different divisions that do it. They're just a human being who comes in who wants the care that they need. And that's what we need to provide.
Ray, I don't think we can hear you.
Yeah.
Oh, sorry. Thank you. Turned on one thing, but not the other. I just wanted to say thank you again to the panelists. We've gone a few minutes over, but really glad that people had so many great questions. I just wanted to note that we are, all of these questions that were submitted are recorded within GoToWebinar, so we'll be able to compile a lot of these and try to get more answers. And I see that some of our partners even have offered answers to the pharmacist question about pilots that have been done around increasing vaccination, so we can share his information, or we'll follow up with him to get that information. But I just wanted to wrap up really quickly to summarize some of the congressional asks that Jason and our other panelists did run through, related to broadly, not just hepatitis B vaccination, but also viral hepatitis advocacy programs. One way that congressional offices can join in is to have your members become part of the Congressional Hepatitis Caucus. So staff can reach out to Grace Meng or Hank Johnson's office to join. They're the co-chairs of the caucus, or you can reach out to any if you're an advocate and you want to know how to send an email out to your member to try to get them to join, you can contact us. There's still the resolutions out, the House resolutions. I think the House one currently has around 10 co-sponsors, and I know this is something that will need to be reintroduced next year too, so we'll have an opportunity to get more members on board to recognize April 30th as an awareness day. And as Jason mentioned, and just thinking in general of all the work that needs to be done with viral hepatitis, we are always calling upon Congress to help increase CDC funding for viral hepatitis programs and for infectious disease consequences of the opioid epidemic, since there's so much opportunity and overlap there. And we also have efforts, or we have report language and other materials that can help guide potential administrative and legislative change that would improve collaboration and coordination of efforts around adult vaccination. On the next slide, the community advocacy, you can join our grassroots network to receive policy updates, federal, state, and local advocacy news and action alerts. The link is there on the slide. We have a new blog post up about adult Hep B vaccination, and the foundation is also excited to announce that we are launching a new a new prevention policy program that will be focused much on policy change to increase adult hepatitis B vaccination coverage. Since it's still April 30th, you can also check out our social media toolkit to share some graphics and use the hashtags adult Hep B Vax Day or Be Vaccinated to help us raise awareness. And of course, if you don't already know your hepatitis B status, you can get tested and get vaccinated if you're not already protected. So thank you guys for sticking with us as we went a little bit over, but it's always exciting to see. Again, we know everyone's really busy, swamped right now with different personal and professional priorities, but we had over 200 people attend, which is amazing, and we will send a follow-up with the full video recording, the slides. We'll post it on our website, and we will try our best to go through those remaining questions and connect people with each other to answer them. And thank you again to our partners listed here on this slide. We really appreciate the coordination on this to bring attention to adult Hep B vaccination. I think we'll
Yeah,
wrap
can I
it up there. Thank you guys so much.
Thank you.
Thank you,
Bye.
especially all the Maryland folks. Thank you for all your work on the Hep B pilot, especially Jane Pan.
Yes, shout out to Jane Pan. Thank you.